Now we'll talk about something that is very clinically relevant, and that is blood pressure. Know by default, when we mention blood pressure, we mean the blood pressure inside of the arteries. If you wanted to specify venous blood pressure, you would actually have to specify it because, again, by default, whether it is in an educational setting or clinical setting, blood pressure tends to mean arterial blood pressure. So what does blood pressure mean? When the ventricles contract, it will push the blood into the arteries, and that would lead to a force. The blood is now forced against the walls of the blood vessels, and that's what that pressure means. So blood pressure is the force of the blood that is exerted against the inner walls of the blood vessels as the ventricles contract, and that it is measured in the units of millimeter mercury. So we would expect blood pressure to be high during ventricular systole, and there would be a fall in blood pressure during ventricular diastole. So we have two different pressures going on. There is a systolic pressure, and that's the maximum pressure found that happens inside of the blood vessels, inside of the arteries, to be specific, during ventricular contraction. And then there's diastolic pressure, and that is the minimum pressure that remains inside of the blood vessels during ventricular diastole. The difference between these two pressures is known as a pulse pressure. So your pulse pressure is equal to the systolic pressure minus your diastolic pressure. Blood pressure is really usually stated as a fraction where the systolic is on top and the diastolic is the denominator on the bottom. And normal is about 120 over 80. It's obviously a range, but that is the average normal. Arterial blood pressure is measured usually with a sphygmomanometer, and you can see here how the blood pressure is the highest in the largest arteries. So in the aorta and the bigger branches, those have the highest pressures. And then as the blood starts to flow into the smaller arterioles and into the capillaries, the blood pressure drastically decreases until it reaches really the veins, and you can see that here in the vena cava, it's almost zero. It's not zero, but it almost is that low. So blood pressure tends to decrease as you go further away from the left ventricle. So know that the vascular system, if you put all of these blood vessels kind of like in a line, that could go up to about 100,000 miles long, okay, including the capillaries and everything. So the further you are away from the left ventricle, obviously the pressure is going to be low compared to the aorta that is right off of the left ventricle. So what are the sites for measuring arterial pulse? We usually use the radial artery, okay, at the wrist. But what if you cannot feel the radial pulse? What if somebody comes in and they have a bilateral, maybe amputation of the hands? There are other blood vessels that we could look for to measure a pulse. There is the brachial artery at the elbow. There is the temporal artery on the temples on either side. The facial artery on the lower border of the mandible. The carotid artery, and that is found kind of like in the middle of the neck. What you do not ever want to do is to try to find the pulses of the carotid arteries on both sides at the same time. You want to, if you're checking for the carotid arterial pulse, you would do it one side and then the other. The femoral artery is all the way down here at the origin of the lower limb. The popliteal artery is in the back of the knee. Posterior tibial artery is on the medial side of the ankle. And then the dorsalis pedis artery is all the way on the upper part of the foot. So again, for circulation, if you cannot feel the distal blood vessels, you can start going proximal to find if those are felt or not. So let's say you cannot feel, especially in diabetic patients, because they are more prone to atherosclerosis and gangrene, which is something that you really want to keep an eye in for in diabetic patients. They will always get their pulses checked. So the dorsalis pedis artery, that is one of the more distal arteries. If you cannot feel that, you want to go and make sure, well, maybe I can feel the popliteal artery and make sure that it is felt, meaning that there is blood flowing into the area. If I cannot feel that, I can go and check the femoral artery and see if there's any blood going into the lower limb. Coldness in the lower limb, tingling, and so on, especially in diabetic patients. And if you cannot feel these pulses, that is something like of a red flag that you would need to further investigation. Now, what are the factors that influence arterial blood pressure? An increase in all of these factors that we're going to discuss would lead to an increase in blood pressure. So all of these factors are directly proportionate to blood pressure. And those are blood volume, heart rate, stroke volume, blood viscosity, and peripheral resistance. So we are going to discuss these one at a time. Now, blood volume, that is the amount of blood that is circulating within the circulation. So we said on average, an average adult has about 5 liters of blood. This is going to obviously vary by age, by the size of the body, and by gender. Blood pressure is directly proportional to the blood volume. So if somebody is bleeding, for example, okay, so there's hemorrhage, that leads to the decrease in the amount of blood circulating. So a decreased blood volume, that translates into a decreased blood pressure. Now, stroke volume and heart rate. So let's define what those are first. The stroke volume is the amount of blood that leaves the ventricle and enters into the artery with each ventricular contraction. That is about 70 milliliters of blood per beat. While the heart rate is the number of heart beats per minute, or the number of ventricular contractions per minute. And that, again, depends on the pacemaker. So that's about 60 to 80 beats per minute. Now, the cardiac output would be multiplying the stroke volume times the heart rate. So the cardiac output is the amount of blood, or the volume of blood, that is discharged, pushed out of the ventricle each minute. So again, your cardiac output is the stroke volume times the heart rate. And this is an equation that you have to be familiar with. You might be given a heart rate and a stroke volume and asked to calculate the cardiac output. So you would know that the cardiac output is how much blood is pumped out of the ventricle per minute times how many beats per minute. And that gives you the amount of blood that is pumped out of the heart per minute. So again, your cardiac output would be your stroke volume, say 70, times the heart rate, 72, and this would be your cardiac output. If anything of these increase, your blood pressure increases. So an increase in stroke volume or heart rate or cardiac output can lead to an increase in blood pressure. Now for the peripheral resistance, and that is the force of friction between the blood and the walls of blood vessels. So as the blood is pushed through the blood vessels by the heart, the blood is going to rub against the walls of the blood vessels, so that friction is the peripheral resistance. The blood pressure has to overcome that resistance. So if the blood vessels constrict, that means that the peripheral resistance is now higher, and that increases the blood pressure. And the opposite is true. If the blood vessels dilate, so vasodilation, that decreases the peripheral resistance, which translates into lower blood pressures. Next is blood viscosity, which is how thick or thin blood is, meaning how many cells are found in the blood cells, your RBCs, white blood cells, and plasma proteins. Viscosity really is more related to the number of RBCs and plasma proteins. So the more you have of these cells, the higher the viscosity of the blood, making the blood thicker. And again, obviously that will translate into higher blood pressures. Okay. So, for example, in anemic patients, those anemic patients have low RBC counts. that leads to lower blood viscosities, and they tend to have low blood pressure. So how is it that we can control blood pressure? Blood pressure is determined by cardiac output times the peripheral resistance. So that's another equation that you want to be familiar with. You can be given the cardiac output and the peripheral resistance and asked to calculate blood pressure. So blood pressure, again, is your cardiac output times the peripheral resistance, meaning that if anything of these change, if these increase, your blood pressure increases. If these two decrease, your blood pressure decreases. So they are all directly proportionate to each other. So in order to maintain a constant blood pressure, you can do so by controlling or regulating these two forces, your cardiac output, which again, remember, was heart rate times stroke volume, or changing the peripheral resistance. So let's take a look at the scenario here. What happens if a patient has high blood pressure? If the blood pressure goes up, again, those are picked up here by your baroreceptors that are found in the arch of the aorta or at the carotid bifurcation. So those are known as your carotid and aortic baroreceptors. The afferent neurons take it to the CNS. Now, what do the efferent neurons do? What are the effectors in this reflex? So you have the smooth muscles of the blood vessels. Okay, those are going to relax, leading to the dilation of blood vessels. That is one way to lower blood pressure back to normal. And your other effector would be the heart. Okay, so through the parasympathetic, we could increase the parasympathetic impulses to the heart or decrease the sympathetic impulses to the heart. In both cases, that will lower down your heart rate and lower down the stroke volume. Now that you've lowered everything, you've lowered all of these in that equation, you lowered your peripheral resistance by dilating the blood vessels, and you've lowered the cardiac output by lowering both the heart rate and stroke volume. All of these factors together translate into bringing the blood pressure down back to normal. Now, what happens in the reverse scenario? If somebody, let's say they're bleeding a lot and their blood pressure goes down, how does the body try to compensate for that and maintain a normal blood pressure? Well, again, your receptors are the same, the aortic and the carotid baroreceptors. As for the effectors, those are the same as well, but they are going to perform the opposite. So on the blood vessels, we're going to stimulate the smooth muscles to constrict. So there will be vasoconstriction, increasing the peripheral resistance. And to the heart, we will increase the sympathetic supply or sympathetic impulses going to the heart to increase the heart rate and the stroke volume. Now, all of these three factors together would lead to blood pressure going back to normal. So make sure that you're very comfortable with this scenario in either directions, whether it is high blood pressure or low blood pressure, and how does the body correct it. Now, hypertension is a very common problem or very common diagnosis. And hypertension means a long-lasting elevation of arterial blood pressure. So it's not where a patient comes in and you get their blood pressure on that one time, and then you just diagnose them with hypertension and you start them on medication. That's not really how it works. It could be that the patient is just nervous, just being in a clinical medical setting. So you want them to relax and say, you know what, I'll give you a couple of minutes and then I'll measure the blood pressure again, or ask them to maybe come in a week later. Maybe there's something going on at home or at work that is stressing them out, leading to that high, that one-time high blood pressure reading. So it's not a diagnosis that you'll make kind of on the spot. You have to repeat the measurements. So hypertension is long-lasting elevated arterial blood pressure. Sometimes the causes are unknown. It tends to run in families. It tends to be more in the African American and in the Arab American communities. It is it related to the genetics? Is it related to diet? It could be both. So Common risk factors are increased sodium intake, so increased salt intake, psychological stressors that are going to activate the sympathetic nervous system, so that very long exposure to stress can lead to hypertension. Obesity, due to the increase in the peripheral resistance, and then kidney disease. So hypertension in the case of kidney disease would be secondary hypertension, where the primary diagnosis is kidney disease. And then through the renin-angiotensin system, that will mediate the secondary hypertension. And if you're not familiar, or if you do not remember what the renin-angiotensin system is, I would recommend that you go back and review that. Hypertension is considered a silent killer because most of the time there really aren't symptoms to point to having blood pressure unless the patient actually goes in and gets their blood pressure checked. Sometimes it goes unnoticed. It does contribute to atherosclerosis. It is a risk factor for developing strokes and heart attacks. The best way to treat hypertension is actually prevention. So you want to prevent it from happening through promoting healthy diet and weight loss, promoting regular exercise and limiting salt intake. If it does happen, you can treat it through these factors, if it's, provided that it is not too high of a blood pressure. But if it is, then you have to start them on medications. Commonly, we start them on diuretics to kind of get rid of some of the extra blood volume, or sympathetic inhibitors. So remember, the sympathetic system constricts the blood vessels and leads to tachycardia. So a sympathetic inhibitor would do the opposite, where the blood vessels would dilate and the heart rate would go down. And this ends this part.